Dr. Perlmutter, what are microglia and why haven't they gotten the respect they deserve?
Microglia, and that's a very important name for people to remember, are the components of what's called the brain's innate immune system. And what that means is really quite interesting because the whole notion that the brain had its own immune system is a very new idea. It was thought for years that, well, if there's an infection or something in the brain, that immune cells would come from the rest of the body, work their way through the blood-brain barrier, and deal with the infection. And to some degree, that's true. But we now recognize that these microglial cells live there, and they represent immunity in the brain. They've been seen for years and years, and they were thought when you looked at them just on a slide under the microscope, you'd see these cells connecting neurons, and you thought, well, they're the glue. And that's where the term glia comes from. Microglia means glue. And it was thought that these were just structural components holding the brain neurons together. But the reality is they're always moving around looking for things, looking for something to tidy up. So they are the immune system of the brain, but they do a lot more than that. And that's really what's so exciting is, beyond just being on guard for infection, they're actually, when they are happy, and that's really, I think, the central part of what you and I are going to talk about today, what we call M2, they're doing much more than just dealing with infection or waiting for something to happen. They're nurturing the brain cells. They're keeping the blood-brain barrier intact, and they're actually fostering the formation and stability of synapses, which is where one brain cell connects to another, which is really fundamental as it relates to learning. So these are the cells called the microglial cells that are taking the front of the stage now. They're in the spotlight because when they go south, when they become dysfunctional, it sets the stage for every type of brain degenerative condition that you could think of.
Okay, well, let's talk about the two different phenotypes, M2, M1. Best we can, we want them in the M2 state. Let's talk about why they would switch and what inputs cause that.
Very good question. And this shift in the brain's immune cells away from being friend to being foe, shifting from M2 supportive to being M1 destructive, to be fair, that's a construct that neuroscientists have created for simply understanding this shift. There are a multitude of different phenotypes between M2 and M1. In other words, it goes through a lot of different iterations until it's a full-on M1 destructive. But unfortunately, one of the main issues that forces our supportive M2 microglia to becoming M1 is age. And, people would say, well, you can't do anything about that. You can't reduce the number of birthdays that you have. But here's where the story gets really interesting, because it's not our chronological age, in other words, the number of times that we've gone around the sun. It's our biological age. It's the marker of how youthful or aged our bodies are. And we can now test that with some very interesting blood work called methylation clocks. So this is a determinant in terms of, do you shift from M2 supportive to M1 destructive? But really important, because these are levers that we can pull. One of the major drivers that we can control, actually there are two really important ones, and we'll talk about them. Number one is inflammation anywhere in the body that makes its way to the brain. And number two are metabolic changes, like increases in our blood sugar and our blood pressure, loss of insulin functionality. Things over which we have great control can help us keep our M2 microglia doing their job, our microglia in their brain defenders kind of phenotype, as opposed to nudging them towards becoming the evil twin. And let's be clear, this shift of the microglia from supportive to destructive is now looked upon as representing the central feature in all neurodegenerative conditions, including the biggies like Alzheimer's and Parkinson's and frontotemporal dementia and progressive supranuclear palsy, multiple sclerosis. We could go on and on. But isn't it incredible that these diseases are now looked upon for their similarities as opposed to their uniqueness, their differences? So it really allows us to vociferate lifestyle changes that reduce inflammation and bring us back to our metabolic health as being important inroads to overall brain health and reducing our risk for having our microglia shift to being destructive, paving the way for brain degeneration.
Okay, in a general sense, M2 is where we want to be. But in a normal, healthy brain, what would that ratio of M1, M2 be?
Difficult to say. It's, as I mentioned, very, very age dependent. It can change from 1 to 1 to 1 to 2 and 1 to 8. In other words, a much more likelihood of M1 phenotype destructive microglial cells as we age, and certainly as we become metabolically compromised. Pretty much you can't slow the hands of time, though I mentioned biological aging is certainly, more important than chronological aging, but we sure as heck can bring our metabolic health back into where it needs to be in terms of reining in our blood sugar, re-establishing insulin functionality, reducing inflammation. So, that's a key player here, that the chemical mediators of inflammation that we call inflammatory cytokines can be produced anywhere in the body, including, for example, the gut. When the gut has issues with the gut bacteria, the microbiome, and becomes leaky, then these chemicals are produced in the body, these inflammatory cytokines that go by fancy names like interleukin-1 beta and tumor necrosis factor alpha for those who want to take the quiz when you and I are done today. But anyhow, they make their way to the brain and they force these supportive brain defenders, the M2 microglia, into being destructive. This is well before we get these accumulations of things like beta amyloid. It's been thought until quite recently, I mean quite recently as in within a few months ago, that the cause of Alzheimer's disease was beta amyloid. That's what the notion has been for several decades, to the extent that, the FDA approved drugs to lower beta amyloid as a treatment for Alzheimer's disease. The drugs do not work. This was finally codified, if you will, by what is called a Cochrane analysis. This is a large-scale study that basically looked at all of the well-conducted scientific research at evaluating the effectiveness of these beta amyloid FDA-approved drugs for the treatment of Alzheimer's. This study was just published, a review of 17 publications comprising 20,345 patients, and it found that the utility of these drugs was, in their words, trivial, and there was a significant threat to using them. So we now understand that well before and well beyond beta amyloid accumulation in the brain are these changes in the brain's microglial cells that we've been discussing that really presage not only the accumulation of beta amyloid, but the cognitive decline that defines this illness.
To riff off of what you just said there, this recent Cochrane review, these drugs, as you mentioned, didn't have a meaningful effect on things for people with Alzheimer's, but also, you touched on this, there was negative side effects.
That's right. And, to be fair, doing the right thing in terms of treating a patient is to look at what is called the risk-benefit ratio. In other words, you look at the risks and you look at what is the upside. Here, there's no upside, and the risks are significant. About 23 to as many as 28% of patients receiving these drugs experience what is called ARIA, A-R-I-A. It's an acronym that means amyloid-related imaging abnormalities. What does that mean? It means that patients on the drug, 28%, are going to have changes in their MRI scans when they are followed, as they should be, which includes edema, which is swelling in the brain, and also hemorrhages in the brain. In 28, more than a quarter of these patients get these things, the long-term consequences of which are not known, but I don't think can be good. Hemorrhaging in the brain and swelling, I can't imagine that's good for the brain. And even the name amyloid-related imaging abnormalities? No, it's not amyloid related. If it were amyloid related, we would have seen these abnormalities on patients prior to treatment. So to be fair, it's treatment related imaging abnormalities. And the other thing is the drugs were originally developed and petitioned the FDA to modify Alzheimer's disease, the cognitive decline. It was found that the drugs had no effect on cognitive decline of any meaning. So then the creative manufacturer said, well, okay, we're losing that battle. What else can we do? Oh, let's see if the FDA will approve our drugs for removing beta amyloid from the brain, because as we all know, that's the cause of Alzheimer's. It isn't. But anyway, they were quite successful in showing that their drugs removed beta amyloid from the brain, and the FDA gave them approval then. But that doesn't help patients in terms of their clinical course. That's the bottom line here. Not a biological change of ridding the brain of beta amyloid. That's not the issue. That's not our goal. Our goal is to slow the cognitive decline. That's one goal. Arrest the cognitive decline. That's a better goal. Or improve cognitive function would be the home run we are all looking for. And as we recognize that these microglial cells, the brain's immune system, the first question you asked me today, are really upstream of all of this, the cognitive decline, the loss of synapses, the accumulation of beta amyloid. Whatever we can do to keep those microglia intact and in their brain defending role and nudge them back to being this M2 configuration when they've become brain threatening is really got to be the goal. And it's incredible to see how much research is now being dedicated using this as a platform.
Let's talk about mental health now and the connection between this M1, M2 and how that fits in.
First, I would say that we have gained an understanding that many of our mood disorders, like anxiety and certainly major depressive disorder, have a powerful inflammatory component. And as such, we assume, therefore, that this is going to shift those microglial cells from M2 to M1. This is relatively new. I mean, there are now, books written that look, one is called Brain Energy, that looks at the energetics of what's going on in the brain, in the neurons and in the microglia from an energetic perspective, really focusing on the idea that when we shift away from mitochondrial function, we're setting the stage for increased brain inflammation and polarization away from being helpful of our microglial cells. So it's a very, very good question, very good point. Why so? Because it takes us out of the realm of being solely dependent upon drugs to realizing that lifestyle interventions may play a role here. Now, we've known for years that there can be some significant benefits of lifestyle intervention in patients, for example, with chronic depression, with respect to dietary changes and exercise and paying attention to sleep, for example. What are the mechanisms? Well, inflammation, improved insulin sensitivity, increased production of new brain cells, which seems to be something very important in the treatment of depression. So we move away then from this idea of lack of serotonin is the cause of depression to these other issues that, researchers and clinicians like Dr. Uma Naidu at Harvard and Christopher Palmer, the author of the book that I just mentioned, have made so clear to us. And I will refer back to an earlier part of our discussion where we talked about the imaging of the activated microglial cells, that TSPO imaging, that is seen to be lit up, i.e. microglial cells have shifted from M2 to being destructive M1, as demonstrated by how these TSPO images light up in major depression, telling us what? This is a shift in the immune function in the brain. And what do we know? We know that that can be brought on by the metabolic changes that we've been talking about.
And this ties back to another earlier part of the chat when we talked about different neurodegenerative conditions, Parkinson's, Alzheimer's. I asked you about, now that we have this information, how you look at maybe there being a common thread there Now we can bring mental health challenges in. Do you look at them under the same umbrella?
Absolutely. In fact, I unpack, as you know, I unpack that quite a bit in the book. Brain Defenders is not just about Alzheimer's. It's about mood disorders. It's about autism spectrum disorder. And it's about Parkinson's, and really, a global approach to brain health. And I think it's so important that we drive home the point that depression is a brain-related disease, that mood disorders, psychiatric issues are related to the brain. Why am I emphasizing this? Is because I had an interview the other day with a Dr. Daniel Amen, and he does SPECT imaging of individuals with brain trauma, Alzheimer's, and mood disorders like depression as well. And he said something very interesting. He said, psychiatrists are the only discipline or specialty that doesn't study the very organ that's involved in their specialty, the brain. They don't image the brain. They don't, and that's what he has done for 30 years, SPECT scanning of the brain to determine what areas are involved. And now he's able to predict, by looking at a brain SPECT scan, who will respond to what particular medication might be used. So I think it's very important to understand that these are brain-related disorders, though they may be significantly influenced by issues outside of the brain, like in the gut. There's a lot of work being done now relating and emphasizing the relationship between dysbiosis, the changes in the gut bacteria, and risk for depression, for example, through the mechanism of inflammation.
You made it to the end of this clip, which means you're gonna love the full episode. Head on over here to watch, and I'll see you over there.
These are the cells called the microglial cells that are taking the front of the stage now, because when they go south, it sets the stage for every type of brain degenerative condition that you could think of. When our blood sugar is elevated,